screen. Um, so kind of just to start off, because I feel like this is a major concept that is not only used in this course, but throughout the different courses, is um, this kind of flow chart, which I'm sure you guys have seen before, I think in Dr. Hong's section of CVS. Again, if there's anything that I mentioned, first of all, that you guys like haven't covered, like stop me, let me know. I'm sure that things are the same, and we kind of confirmed with Dr. Doyle Campbell that things were the same, but just in case, like, please let me know. Um, but we kind of have some contributing factors to ASCVD, and we know that it can be grouped up into four different types. So I wanted to see if anybody had any ideas. We'll start with like the four different types that it's classified in. Does anybody at least know one of them? Do you want to like shout it out or type it in the chat? It's okay if we don't know. So I'll say this one. Okay, yeah. Coronary artery. Okay. I got coronary heart disease is one, so that's the first one that we see here with MI, heart failure. Additionally, we have stroke and TIA. We have aortic aneurysm, and we have peripheral artery disease, which again, PAD isn't one that really comes up often in CVS 1, but just to keep it in mind for the future. And these are things that we're going to be concerned about, progression, right? Because we know that this starts with endothelial damage of some sort, and that initiation will cause progression and damage over time. So that's things that we're trying to prevent with our therapies for decreasing cholesterol and also for your antihypertensives. So based on that, I kind of already said a little bit about it, but we have some contributing factors that can cause this initial damage, right? So LDL levels can be increased. HDL levels, which we know is our good cholesterol, those can be decreased and cause an issue. And things such as environmental factors and what the patient's doing. So, smoking is a contributing factor that can cause damage over time. Hypertension is a contributing factor. So that's kind of why we are doing what we're doing and targeting things early in order to prevent all of these major cardiac events in the future.
Yeah, and another big thing, as well as diabetes too. Diabetes is also a major factor, especially on the exam and in real life as well. You're going to see a lot of patients with diabetes. And a big thing with these, you're probably not going to get asked this like on the exam or anything like that, but for your future classes, when you have to do like your OSCEs and stuff like that, you're going to get a lot of situations where patients are going to ask like, "Oh, I don't feel like this medication is doing anything." Like with your statin, they're like, "Why do I have to take this?" So you have to like, it's a lot about counseling and knowing the reasons why behind like why these patients are taking the medication. So like for statins, you have to explain to them, yeah, this is to prevent you from getting like a stroke or a heart attack or something like that in the future. So yeah.
Um, so now we kind of want to just do a little overview with classes of anti-hyperlipidemic drugs. So the first one we have our cholesterol absorption inhibitor, and there's really one main one that I know you guys talk about. Does anyone remember or have an idea about what that one absorption inhibitor is?
Ezetimibe.
Yep, yep. So this one's really important and kind of, I don't know if they went over details about why this is really only used as an adjunct therapy. We know a lot of people are put on like statins and things first line, but this can be added on afterwards, and that's because this is targeting, dietary intake of cholesterol, right? Which only accounts for about like 15 to 20% of what we actually have in our whole body, which is why this can be helpful, but not solo on its own as a first line treatment. Then we move on to our cholesterol synthesis inhibitors. So this is going to include our things like statins, which I kind of have it on the slide so you could see, but does anyone have an idea of what enzyme that's targeting, like what the class is for our statins?
You can type in the chat as well.
It's okay if we don't know. Yep, yep, good.
Perfect.
HMG CoA reductase inhibitors. And also, I kind of have like 2A, 2B listed here because there is another one that is like targeting cholesterol synthesis. And that is bempedoic acid, which we know works as an acyl inhibitor. So this just works earlier in the process. So it's really inhibiting that first step of converting citrate to acetyl-CoA. So kind of the same outcome, it's just a different step in the pathway that it's targeting.
And does anybody know why we'd prefer to use statins over bempedoic acid?
Because isn't like HMG CoA reductase the rate limiting? Yeah, what Alex
Perfect.
just said. It's
Exactly.
the
Yep.
rate
So
limiting
so
factor.
that enzyme is the rate limiting step. So that's why we target that. Absolutely perfect.
That's usually a question like on
Yeah,
the exam.
that's
So
definitely going to be a question on the exam.
yeah. Um, and then, okay, number three, we have increasing our LDL-C reuptake. So this is through our PCSK9 inhibitors, right? Just a general question, because I know that when I like reviewed this first, this can kind of be an interesting topic to get your minds around at first. But if you are increasing your LDL receptor, how does that affect your plasma levels of LDL? Does it increase or does it decrease? Right? It lowers. And that makes sense because it's bound and, we talk about that whole process of LDL recycling. That's being promoted in that case. And then for our fourth one, we have our ones that increase bile acid excretion. So this is going to be our bile acid sequestrants. And again, we don't really see these as much in practice, but it's kind of important to know their mechanism. I know that Mizuno really does like to ask about
I think
the
this is
med chem.
this is going.
Oh,
Yeah.
oh, you do. Sorry. Yeah,
Yeah.
Dr. Gonium does like to ask a lot about like the med chem of it, which I'll go into in another slide and point out specifically what I think that you guys should know from that. Um, but yeah, so we already answered our little question on the side. So
Perfect.
okay, so for our statins, I kind of created this little thing because I think this like helped me learn this and memorize like kind of the SIPs because as you get going on, like you get so many SIPs that are thrown at you, and this just helps you remember. So with our statins, remember we're concerned about CYP3A4 for specifically SAL. So that is simvastatin, atorvastatin, and lovastatin. So kind of I just like a little image here to help you remember there's three little salt shakers. So that is for CYP3A4. And then there's one that's kind of a little bit different, which is rosuvastatin, which we know is a substrate for CYP2C19 instead. So if this can help you on the exam, just remember the little 19 rosuvastatin pills that I put on this slide. Just something fun to help you remember. And then in terms of medchem, we know that there's an intermediate, right, between when you have the process of like your HMG CoA reductase working. And the intermediate has an opening in this ring. So whenever you see this structure, there's kind of three main pharmacological aspects of a statin. So does anyone like remember or want to list like the three different components that I have highlighted here that are vital for the pharmacology of a statin? Or even if you know one of them. There's three specifically, and I know that Dr. Goning likes to ask about this.
Dr. Gonim is still doing your med chem, correct? Right? We're not just
Anybody like thumbs up, thumbs
yeah.
down?
I don't know. I was like, oh, okay. I was like, DLP, we didn't even get a lecture. We just got slides.
Okay.
Oh, okay.
So did you guys like go into like
Hong
structure of
said this
statins at
morning all he
all?
wants us to know is the pharmacomatospore of the statins.
Okay.
Okay, so yeah, that's what
Okay.
this would be.
Yeah.
So the first one up at the top is the lactone ring, right? And then you have the ethylene bridge, and then you have that hydrophobic fatty moiety at the bottom there. So in order from top to bottom, and that's really, those are the main components there. Again, I don't know exactly what Dr. Hong told you guys, but just remember those if he wants you to know the pharmacophore, those are the main components of that. And then can someone like tell me if you guys like talked a little bit about like the difference between like the prodrugs? If not, I won't go into it because I don't want to like confuse you guys. No. Okay, then
Okay,
skip it.
cool.
So kind of similarly, at the bottom one is kind of similar to the last one, so I'll skip it, but just kind of so you guys can understand some of the side effects of your bile acid sequestrants, like such as questrin, cholestyramine, colesevelam. So these ones, we do see like a positive charge on them, right? So that means that they're going to be localized within the GI tract, and they're not absorbed. So there's certain adverse side effects that we're going to be concerned about here, right? You may see more constipation, we may see more bloating in these patients, and definitely counseling our patients that we want them to take this after meals, right? Because that's just when bile acid is actually excreted. So if you don't have a meal in your system, it's not going to work. And then we kind of talked about Zetia a little bit already. Again, if that's all he wants you to know for MedChem, I won't go too much further on that. But any questions related to what I just said at all? If there are any, please just stop us. Okay. Okay. So this is for calculation of CLDLs. I'm sure that you guys went over this. Again, if not, stop me. But if you guys want to take just a few minutes to kind of calculate this and tell me what you got.
There will be at least one question on the exam where you have to calculate a CLDL. And it's going to be like a case question. Like you'll get all the information that's needed and you're probably going to have to calculate it. Probably. Most likely.
At least for us, it was
Yeah, at
definitely
least for
there.
us, yeah. There was at least one I remember. Gotcha. Okay.
Okay, Alex said 174, an error. I love it. Yeah, that's right. So 174, right? Because we're doing the total cholesterol minus the HDL minus triglycerides over 5. So we get 174 or 173.6, and then we can round it. That's absolutely fine. And then the last one, right? Triglycerides are, it's above 400 is typically like the range. But you're right in the fact that this is too high, so we wouldn't be able to get an accurate reading with this. So good job. Okay. This is a fun little case. So we have Jacob Wattis, right, presenting to our AmCare clinic for a medication consult. He was recently prescribed simvastatin 20 milligrams by mouth once a day. He's been adherent but has been experiencing some muscle pain. He's denying severe back pain or changes in the color of his urine, right? So from that last sentence, we can rule out things like rhabdomyolysis, which we know is a little bit more severe and can present with those same symptoms. So that's the first thing that we want to make sure it's not emergent. So if he needs to stay on a statin therapy, and let's say we've gone through the process of taking him off of it, putting him on the same statin, so we know that it's caused by this. What statin can we recommend that has a lower risk of myalgia? Watch out. Watch out and go to RAP. So yes, so there's pravastatin that we could use. There's a low dose rosuvastatin that we can use. Fluvastatin is also another one that has a lower risk of myalgia. Atorvastatin, not as much, like if you're putting somebody on a high intensity statin and you're kind of comparing the two, rosuvastatin's definitely better in terms of muscle pain, but definitely pravastatin. That's the one that is the most hydrophilic. So we don't see as much of a risk with that one.
And do you guys know what causes the, or like what increases the risk of somebody having of having muscle pain symptoms, depending on the statin? Like what specific characteristic of the statin will cause that?
Like the more lipophilic it is, the more likely it is to cause an ADR.
Yep, correct. Very good. Yep. So, I think there might be one question in the exam where they'll give you two structures of statins and they'll give you the log P, right? And so what do we know about log P? Right, very good. Yeah, so the higher the log P, the more lipophilic a drug is. So we'd want to choose the statin with the least amount of lipophilicity if the patient is having muscle side effects. So I believe for pravastatin, the lipophilicity is like 0.7 or something like that.
Mhm. Nice. Um, okay, just as like a follow-up, let's consider the fact that maybe, he wasn't having any muscle pain, right? He's been on simvastatin 20 and he's fine and he's good with the moderate intensity. Um, and then he has newly diagnosed hypertension, and his doctor is saying, "Hey, can we start him on amlodipine? I know it's 20 milligrams by mouth once a day, but what's kind of a concern? Like, is this okay, or is there anything that we're concerned about?"
I think the CYP3A4 interaction.
Yep,
Very
yep.
good.
So, just as a reminder, max dose, if you're using both of these together for simvastatin, is 20. So if something happened in the future, I mean, he would be fine on this dose, but if something happened and we needed to increase his statin level, we wouldn't really be able to do that on that treatment. So that's kind of just a thinking ahead and being preventative there. And then we know, kind of to shorten this question a little bit at the end, but um, grapefruit juice, what sip does that work on and what does it do? Yep, CYP3A4 inhibitor. Nice.
And this grapefruit juice like counseling point is something very big that you'll like see it's like low-hanging fruit, but like they were telling us that like in order to this actually have an effect, like you'd have to drink like liters of grapefruit juice to have like any actual effect, but it's still like something that we counsel patients on.
Like a ridiculous
Yeah,
amount.
and I think people who actually drink grapefruit juice are like insane. It's just
That's a personal opinion.
personal opinion.
Okay. So I just felt like that this was really important, especially as you're going through cases where sometimes they may give you multiple answer choices that are technically correct, right? Like they can work out for your patient, but there's a specific detail that's listed in there on why one may be preferred over another. So kind of emphasizing and focusing on this type of chart where you're going through and looking at patient factors, looking at their past medical history, looking on other drugs that they're on to see if there's a DDI, right? What are they presenting with to see if there's one that's preferred over another. And one that was kind of not on this chart was for history of liver disease, which wouldn't be a high intensity in this case. Well, if you're not using a high intensity, is pravastatin, like a low dose pravastatin is preferred. So I just wanted to add that one in there, just in case it pops up. But kind of use this chart. I know that I found it helpful, and you can use that in your process of going through cases.
Very good. Yep. All right. Yep. So now we're going to be talking about the goals for our LDL. So EH is a 68-year-old who presents with an LDL of 201. She has a history of TIA in 2024, CKD, and type 2 diabetes. She claims that high cholesterol runs in the family. She smokes 1 pack per day and is not ready to quit. She is currently not being treated for her increased LDL levels. You classified her as very high risk. So what would be our LDL goal for this patient and why? There's a couple reasons.
Less than 100 because look LDL is over 190.
Okay, yeah, so I like that train of thought, but there's something else in the case that would make it a little bit more specific, a little bit lower. Kind of what, yeah. So Alex got it in the chat. So it'd be less than 55 because of her TIA, right? So she's already had a ASCVD event in the past. So now we're doing secondary prevention. So anybody who's had an ASCVD event in the past, so that's things like MI, stroke, PAD, or surgery, stuff like that, that automatically puts them at high risk or very high risk. So that's going to be less than 55 for our goal. So if we are trying to get our patient to that goal of less than 55, what would be our initial therapy? The first drug that we would start.
Generally.
Yeah, generally. Yeah,
High
of course.
intensity statin.
Very good. Yep. And then what are our options for high intensity statins?
Atorvastatin 80 or rosuvastatin 20 or 40, but you'd start with 20.
Yep.
Excellent. Very good. Yep. So if we say we initiate the rosuvastatin 20, or let's say atorvastatin 80, and we follow up with her and her LDL level is at 84, which is not a goal, what would we add next? Very good. Yep. So Alex got it. So we'd start ezetimibe or Zetia, right? So let's say that she came back into the clinic and she still wasn't that goal would be the next option that we would use, right? We could use Repatha and then there's one more option as well.
Bempedoic acid.
Very good. Yep. So in the real world, our next choice after starting atorvastatin and Zetia would be completely down to the insurance. Um, just like that's just how it is. Sometimes insurances want people to have the atorvastatin and Zetia, or they want to try all three first before they cover the Repatha. But that's just how it is. So you're more commonly now, I see the Repatha getting dispensed when I work. Um, I think that's just the way that the trend is going to go towards Repatha.
Mhm.
Yeah, very good. So how would our goal change if the patient was not very high risk?
So, like if they had the history of TIA, for example, but we don't have some of these other things. They don't have the family history. They're not a smoker. So maybe just like one major thing. And we're not classifying them as very high risk, but they still have ASCVD, right? So how would that change your goal? It wouldn't be less than 55 anymore. Does anyone have a number?
Less than 70.
Yep.
Very good.
And then Alicia, just kind of to go off of what you said, kind of for our next one, how would the goal change if the patient didn't have a history of ASCVD and it was just greater than 190? In that case, it would be less than 100 for your goal. Does that difference make sense? Does anybody have any questions about that?
And that would be because of the familial hypercholesteremia. That would be the goal for that.
Yeah. And just kind of like what I do when I'm going into these cases is I always like write on my scratch paper these two like basic questions like do they have ASCVD? Do they have diabetes? Because especially with like the risk score for diabetes if they're older than 40, right? And they give you like a cardiovascular risk score for that one, that also plays a role in if they're on a moderate or high intensity statin. So I just like to look at those two things first and say, do they have either one of those? Because that can kind of change how we look at the goals in the treatment, right?
All right, and then here's just this kind of like a chart, but they're not using ACV, right?
Yeah, no, you guys
Yeah.
aren't using
Yeah.
the guidelines changed a little bit compared to when we did it, so just
We can
ignore this right
Yeah.
now. Okay. So kind of to switch over into hypertension a little bit, we know that there's two different types of hypertension, right? So there's primary and secondary. I'm pretty sure this was a question for us, but does anybody know which one is kind of more prevalent than the other? Yep, I see some people holding up ones. Yep, primary. And this is the one that, you know, to kind of differentiate them, like primary, the hypertension itself is the issue. It's not caused by something else. This one always comes up. Also know which organs and tissues regulate blood pressure. I'm pretty sure for us, this was like a type in or something. Like they had you
Yeah,
type in each one. So just in case, I don't know if you did the questions differently, but know those three. And then understanding the formula for cardiac output and contributing factors. So, um, does anybody remember the formula or want to scream it out? Yeah.
very good.
Yep.
Yeah, heart rate times stroke volume, very good. And then the for question number two, it was kidneys, hearts, and blood vessels. Very good.
hmm So, kind of just know in terms of which ones like affect each factor, like know that contractility can increase, uh, it goes in the same direction, right? It's a direct relationship with stroke volume. Preload is a direct relationship, and afterload is the only one that has that inverse relationship, right? I know that he likes to ask questions on these. So I also just put in here kind of the basic definitions for both preload and afterload, just so you guys know. But so in terms of our hypertension treatment, first line, right, we have these three main classes: calcium channel blockers, thiazide type diuretics, and ACEs and ARBs. So when you're going through a case, because again, very similar to what we said last time, you may have multiple options that can work. And I can probably guarantee that they'll give you a case and they'll have one of each class on there and say which one should we do first line, but there's something specific in the case on why we shouldn't choose one or why one is preferred over another. So this kind of just breaks down certain things that we can kind of look for that if you see it in a case, it may, bring your attention to one over another, right? So if you have somebody with a history of peripheral edema, for example, and they don't have contraindications to a thiazide type diuretic or an ACE or an ARB, then calcium channel blockers wouldn't be first line. Same goes for heart failure, avoiding things like verapamil in those cases. So checking your DGIs is super important. For your thiazide type diuretics, we have chlorothalidone, we have your hydrochlorothiazide. Again, either one of those isn't wrong. I think there's like some studies out there that say that chlorothalidone a little bit better, which is why it's more used first line. But if you have somebody with a history of gout, right, we wouldn't want to use that. It's a diuretic. It can decrease the sodium levels, it can decrease the potassium levels. So look at labs, right? If you have somebody and their sodium is, below 135, we're not going to initiate this for that patient. And then kind of just remember those key, side effects that you've talked about in renal for ACEs and ARBs, right? We're not combining them. If you have somebody look at their medication list and, we want to add on a therapy, but they're already on lisinopril, don't choose losartan as an option. History of angioedema. I don't think that they're going to ask you too much about bilateral renal artery stenosis, but just in case that they do, that if it is bilateral, we wouldn't choose the ACE or an ARB, but if it is one-sided, then you could start, low and slow with that and be fine. Remember your potassium sparing diuretics, right? If you have somebody that's taking one of those, maybe initiating an ACE or an ARB wouldn't be the best idea right away because, we want to be monitoring those potassium levels. We don't want them to get too high. But at the same exact time, if you have somebody with CKD and you're looking at their GFR, you're looking at their albumin level, as long as it's not too far below, that can actually be renal protective, right? So it might be beneficial for certain patient populations. And then at the bottom, we're kind of just re-emphasizing that if it's not controlled, start another one. We're not, removing one or you're adding it on. And you're adding them until, they're controlled as long as there's not a contraindication to one of them.
And just to add on to that as well, that also goes for our lipid lowering therapies. So as we start a new agent, we do not remove another agent beforehand. So if we have a statin on board, we wouldn't drop down to like we wouldn't stop the statin to start ezetimibe or something like that. We would keep everything on board to keep that lowering therapy going. So let's talk a little bit about blood pressures. So who can tell me what the ranges for the different types of blood pressures are? So there's like normal range, there's high range, and then there's type 1 and type 2 hypertension. Who can tell me what the different ranges are?
Like slightly elevated is where it's like normal is like 120 over
Yep.
80, and then slightly elevated is systolic is like 120 to 129, and then
Mhm.
type 1 systolic is 130 to 140, and then type 2 is 140 or above, and I'm blanking on the diastolic
I think
ranges.
does anybody know what the diastolic is?
Isn't it over 80 is stage one, and then over 90 stage two?
I believe so. Yep.
Yeah.
Yep. Very good. All right. Good stuff, guys.
Okay. So just kind of putting this into a case to get you thinking about this. Here we have a 56-year-old African American male who presents to your clinic for a medication review. Past medical history includes type 2 diabetes, hyperlipidemia, and gout. He's currently taking metformin twice a day, and he's on a high-intensity statin of atorvastatin, 80 milligrams once a day. We have some lab values for you guys, so just take your time, go through them, and then I'm hoping that one of you can kind of give me your thoughts on what you would start him on for. And we're considering that we have for the blood pressure ranges, it's an average of 2 visits, so you do have the 2 in this case, just assume.
Yep. Always remember that we need 2 readings in order to make any in order to initiate any therapy for blood pressure. That's also like a way that they'll try to trip you up. So just make sure that there's 2 readings.
So even if you aren't sure, like if you have one thing that's kind of standing out in this case that you want to share and we can talk about it, just let us know. Yeah. CCB. Nice. Okay. So for those that said that, I don't want to put people on the spot, but do you want to explain a little bit about why you thought amlodipine?
Yeah, because he's African American is the first, like the big giveaway, so that prevents you from using an ACE or an ARB, at least initially. He doesn't have CKD or anything like that either, so it kind of
Mhm.
throws that one off the table.
Yep.
Between like what's the other one there? The thiazide. I mean, you could do that, but I think calcium channel blocker would be the best for him.
Well, because he has gout, so a thiazide isn't ideal.
Exactly. Yep. And then just to remember, so just because the patient is African American doesn't mean that you can't use an ACE or an ARB. It's just that if there's another agent available, we prefer to use that one first before trying out an ACE or an ARB. It's just because the ACEs and ARBs have less efficacy in the African American population, like in general, on average.
And you're exactly right, Alex. I mean, we don't see the GFR is fine. We don't really see kidney dysfunction here. So
Mhm.
there isn't an overarching reason why I would be pushing for an ACE or an ARP in this case.
Yep.
So nice.
Perfect.
Good job, guys. So I think that that's the end of this part.
Yes, yep, that's it. So
Okay.
now we're gonna move on to doing our Cahoots.
So while he gets that up, do you guys have any questions? I know we kind of just did like a crazy speed run on what you guys have learned so far, but if anything, if you want us to go back to anything, re-explain something,
Yes,
and us
always
a
feel
chance.
free to ask questions.
I hope everyone's staying warm. It's like snowy and gross out right
Yeah,
now.
start. 0. think that's everybody. 14.
Yep. All right, guys, you got this.
Which apolipid protein acts as an LDL ligand? Dr. Hong loves this question. Yep, apolipid protein B. Very good.
And just kind of like follow-up question on that. Um, so if you have like I know we kind of talked about like the ester version of cholesterol, right? That is more lipophilic, right? So if you have higher amounts of CE in something, so that ester form, right? It's decreasing the density. So that's what we mean by LDL, and that's the issue is that there's more amounts of the lipophilic one that's causing all of these issues, and that's why it's low density. Just to
And
have it in.
that's why I want our LDL to be low.
Yep.
Yeah, exactly. Which of the following patients would most likely have the lowest LDL? All right, yep. So let's talk about this, right? So the class of drug that we use is a PCSK9 inhibitor, right? So we're trying to inhibit the PCSK9 and think about the high number of LDL receptors, right? So we're trying to increase the number of LDL receptors in order to pick up the LDL that's in our serum, in our blood serum, right? If there's more receptors, the LDL is going to be able to be taken up more by the cells, right, in our liver. So if there's a high number of LDL cells on the liver, the LDL can bind and be taken into the liver and digested. Right? Does that make sense, guys? They're trying to inhibit the PCSK9.
Nice.
Good job. Good stuff, guys. What is the LDL goal for a person post MI with a baseline LDL of 160? Very good.
Nice. So, right, they're not above one like 90 in this case, but we do see that they have that ASCVD risk factor with the post MI, right? So less than 70 in this case. We don't, I mean, we're assuming in this one that there's no like additional information that would place them very high risk. Again, they would have to specifically state that, so we're not pushing it any further right now.
What is the LDL goal for a person with familial hypercholesteremia with a base LDL of 240? Less than 100, right? So our goal for familial hypercholesteremia is less than 100, and there's no other factors that would make us want to push it lower.
Yeah, the CLDL is 240, so it's definitely above 190. So
Yeah.
bring it down.
What is the LDL goal for a person with diabetes?
So what they kind of mean, this is like a very weirdly worded question. Um, they're kind of referring to the risk score here. So like, yes, you would still have a goal range that you're less than, 70 or less than 100, but it's dependent on what that percentage is, right? So if we're like less than 7.5%, then we're not really considering it as much compared to somebody that is greater than 7.5, then we can consider the high intensity statins and either bring them down to less than 100 or less than 70. So sorry, this one is worded a little bit weird, but that's what they mean by only a percentage. We
Yeah.
still have a goal for these patients.
Right. And I think that is more for I think this will like kind of a change with like the old guidelines with the new guidelines because this was more kind of like for us with the ASCVD
Yep.
risk score
Yep.
because you guys are using Prevent. Right. What is Zach's CLDL? This is a calculation question. Or is there any? Oh, this was probably done in class. She
Yeah.
probably gave us information, so we can skip this one.
Sorry.
Yeah, sorry. All right.
Just assume. What
Yeah,
do you think is
right,
the
exactly.
LDL?
Yeah. Sorry. All right. The MD says that Zach's risk score is 8%. What do you recommend for him?
This is also, let us know because I don't
Yeah,
think
this
you
is
guys
this.
are going
Yeah,
to
you guys
the
have told me
scores,
this. Yeah,
but we're gonna skip
yeah.
through this. Yeah.
Let's see what the next question is. You recommend a high intensity statin for Zach. Choose the appropriate medication. Maybe brand names.
I know, some nice little brand generics.
They're good. Yep, Crestor. So who can tell me what Crestor is?
Rosuvastatin.
Very good, Alexander.
This never leaves you. We just did like a brand generic test
Yeah.
like last week, so
Yeah. You're gonna be taking those brand generic quizzes for a long time.
hmm.
Alrighty, question 9. A statin that lowered an LDL by 45% would be considered what?
Extra points if you choose green. You
Yeah,
could choose it now, just not in the exam.
very good. Yeah, so it's a moderate intensity statin. So remember, there's like the different ranges that for moderate.
Yeah, so high intensity is at least 50% reduction, then moderates between 30 and 50. So
Yep. And then low intensity doesn't really have an indication for use. The only time that we really use low intensity is if somebody has like an adverse reaction to a moderate or high intensity statin. Because in a lot of patients, they will still benefit from the statin. Is that we're just trying to find a dose to like keep them on because some statin is better than no statin. Alrighty. Right, you can't use calculated LDL when triglycerides are above which number?
we mentioned this. Come on, guys.
Very good.
Yeah.
Yep, 400. Awesome. Very good.
Let's see, podium, drum roll. Alex,
Six. Right.
Prim.
And Alicia,
Good job,
nice.
Alicia.
Congrats, guys. Awesome. All right. We'll move into our second one. I think there's a couple more. We can leave this one. We can start this one.
Again, any questions in the meantime?
Of
Just shout
course,
it
feel
out.
free to ask questions. All right. Which of the following statins would be least likely to cause myalgia? Very good. Yep.
Nice.
So that would be fluvastatin.
Yeah,
Very
so
good.
not only is sal for CYP3A4, but it's also for, lipophilicity. So
Mhm.
it helps remember.
Which high intensity statin is least likely to cause muscle pain?
High intensity, right? So yes, pravastatin is one that we could use as a good option, but it's not a high intensity. So comparing atorvastatin and rosuvastatin's better.
Yep. What statin is safest to use in patients with hepatic disease?
Remember the chart is at the bottom of the chart.
Very good, pravastatin. So just something to point out to you guys, if there is like a special characteristic of a drug, it is most likely going to be asked on the exam. So like this with the pravastatin with like the most safe to use in hepatic disease, that's like if there's anything else for like drugs like black box warnings or like specific counseling points, they're most likely going to ask you questions about that on the exam. So just to keep that in mind for your future like studying. All right, which statin can be taken in the morning?
Remember, wrap anytime.
Right, wrap anytime. Yep, very good. Yep, Rosuvastatin. So who knows why these are the ones that we can take at any time? Does anybody know why?
So they have the longest half-lives.
Perfect. Excellent. Yep. Very good. What time would you dose the other statins if they're not using RAB?
The evening.
Yep.
Yeah,
Very
like
good.
before
Yep.
bedtime. Yep. Nice.
Excellent. Good job, guys. So you guys know your stuff. All right, Sailor, good stuff. Jane is on a 3A4 inhibitor. Which medication should be avoided? Very good, right? So the acronym SAL, right? So it's simvastatin, atorvastatin, and lovastatin.
If there's one thing you guys can remember, it's me like just screaming Sal is CYP3A4
Mhm.
and lipophilicity, like both of them.
Mhm. Yep. Which statin should be taken with food? It's another counseling point
Mhm.
question. Lovastatin, very good. Yep.
We
Increases the absorption.
we always use like the acronym like we love food and it's like
Yeah.
LOV, so
Yeah.
something fun to remember it if that helps.
Shit in first
Let's
place.
see, who is it this time?
Saber.
Taylor, nice.
Nice. Good job. All right. I think we got one more Kahoot, and then we can open it up to any questions that you guys have.
You guys are killing it.
I think this one is going to be blood pressure focus, hypertension. that everybody?
Mhm.
Is it one more?
Yeah, we need 14.
There we go.
Nice.
Alrighty. There we go. Alrighty, here we go. What is the effect of aldosterone?
They might still like ask these questions because we're still talking about like ACE inhibitors and ARBs. So like expect to see like maybe some basic questions about, the RAS system. I wouldn't be surprised if they put that on there.
Very good. Yep, decreased potassium. Betty is constipated. Which of the medications is most likely to cause this adverse drug event?
Yeah, so that's verapamil. I think they gave us like in your slides, there should kind of be like a list of different like DDIs and side effects that are associated with these ones. They like to focus in on like them because there aren't too many of your non-DHPs. So just keep in mind adverse drug events. They could still ask you about side effects and things like that.
Right, Max is on simvastatin and you want to add a calcium channel blocker. Which one is appropriate? Very good, right? So who can tell me why amlodipine wouldn't be appropriate?
The CYP3A4 interaction.
Very good. Yep, awesome. Good. Right, Betty has a hypertension emergency with a blood pressure of 280 over 160. What is the goal after 1 hour? Very good. Yep, 25% reduction. The stuff with the hypertension emergency that will be like 1 or 2 questions. So just make sure you know like what the goals are and what they do to treat it. Ben states that he has a racing heart rate. Which medication is most likely to cause this? Would be,
Yep. Hydralazine.
hydralazine. All right, what is Ben's home blood pressure goal?
Yep.
Yep, less than 130 over 80. Anytime they ask for a blood pressure goal, it's almost always going to be less than 130 over 80.
Can
So,
I ask a question really quick? This was
Yeah.
something
sure.
I like really didn't get because like Dr. Doyle Campbell has that chart where it's like clinic blood pressure, like home blood pressure, and like
Sure.
compares them. And she was
Yeah.
saying how like you should tell a patient like that their home like blood pressure goal is like, if it's not that high in the office, it's like going to be less than the goal, less than 130 over 80 at home. But then like if it's higher in the office, the goal is different. Like, I don't know. It was weird. I didn't really get it. Is that
Yeah.
is that important to like focus on?
Not really. Just something to keep
Okay.
in mind is that like some patients experience white coat hypertension.
Yeah.
So like their office blood pressure might be a little bit more elevated than what it is at home, like if they bring in like a home log or something like that. But it's just important to note to like that anytime like you're not gonna have to like differentiate, oh, this person has a blood pressure of this at home, and then this is what it is in clinic. They're not gonna ask you questions like that. No.
No.
Okay. Cool.
Yeah.
Thank you.
And they might ask you, the only thing that they could ask you in that term is that like, oh, this person has controlled blood pressure at home, but in the office it's 150 over something. What is that called? And
And you're like
the
white coat
answer,
hypertension. Yay.
exactly.
Yep.
Yeah.
Yep.
Yeah. Right. Exactly. Yep. Good question. Excellent stuff, guys. Good work. All right. Which of the following has no effect on heart rate? Very good. Yep.
Good.
So the other ones are calcium channel blockers. That one is,
The tunnel is different, but
yeah. And then atenolol is a beta blocker, but that's the only one that doesn't have anything to do with the heart. Righty. All right. Which of the following would decrease due to indapamide? Very
nice.
good. Good work, guys. Good
Potassium.
job. Killing it. Our Mary is on a potent 3A4 inhibitor, which medication would interact.
Eplerenone.
Plerinone. Yeah, it's just the substrate of 3A4. All right. Andy is on hydrochlorothiazide, lisinopril, and amlodipine, and his blood pressure is high. Which medication should you replace? Yep. Very good.
So
Yep.
again, like same class, but just based on efficacy, it's something that can be a little bit better, more first line. So
Yeah.
good,
So,
guys.
yep. Thiazide like diuretics. All right. Andy is on chlorthalidone, lisinopril, and amlodipine, and his blood pressure is high. Which medication should be added? And all labs are within normal limits. Spironolactone, right?
Yeah. So again, like just like an example of one where you're looking at the medications that are already there, like I wouldn't be adding valsartan or something like that since they're already on lisinopril. So just take everything into consideration.
Yep. Even if you guys have like no idea what the answer is, try to rule out the other medications that are like listed as options,
Mhm.
right? So like if I'm going through this, I'm like, oh shit, I have no idea what to do. If I see, oh, they're on an ACE, I'm not going to start an ARB, right? So just try to rule out the different options. Very good, guys. Good stuff.
Toxic one if the potassium is in the upper limit of normal.
We'll go back. Alex, we'll go back to that question after this one. So Aaron has stage 1 hypertension, diabetes, and hyperlipidemia. What do you do? Well, I think she updated this one. Ooh. All right, start medication, right? So anytime, I think it's regardless of what the prevent score is. If somebody has hypertension um, with 2 readings, you always start medications regardless of what the prevent score is.
For stage one.
Yeah, for stage 1 and stage 2 for that matter. So Alex asked, what if the potassium was in the upper limit of normal? So if the potassium was in the upper limit of normal, you just have to use something that doesn't increase um, doesn't increase their potassium.
Mhm.
Yeah. So you have to look at your options.
So yeah, like something like again, how we mentioned like the potassium like sparing diuretics. So like I know they like to throw them in there in the medication
Mhm.
list. So I feel like usually in the cases they're not going to give you like a scenario where it's like it's kind of high,
Yeah.
it's going to be something obvious as to
Yeah.
why you shouldn't use a certain agent over another.
Yep. So like if they're trying to make you pick out that the potassium is high, they're gonna give you like a value like 5.5 or 6 or something like that. They're not gonna make it like 4.9 or something like that, where it's like right on the cusp.
Yeah,
They wouldn't
no,
do that to you guys.
no.
Or at least they didn't do it to us. So sorry, guys. Which medication is best to lower uric acid levels? What are you choosing? Yeah, it's gonna be losartan, right? Because those decrease or they increase the excretion of uric acid in the urine. Good. We got two more questions left. Which medication can increase calcium levels? Very good. Hydrochlorothiazide.
So don't let this trip you up because I know it's like a thiazide diuretic, and we usually associate that with like hypo, right? So like hyponatremia, hypokalemia. But remember, this is the one that we have like the history of gout. We're not going to use it, and it can actually increase calcium levels. So kind of remember those two as kind of different than the other lab values that you may see.
Alrighty, last question. Margaret's blood pressure is 150 over 82, but she states that her readings at home are at average 120 over 70. How would you classify her blood pressure? It's kind of like exactly. Very good. Yeah. So this is like
This
literally the exact the exact question that we talked about earlier.
this is what you would see if they
Yeah.
give you something like that, a question like this.
Yeah. Exactly. Alrighty. Podium time.
All right, nice.
Alicia
Alicia,
and
last one. Alex.
Alex. Nice. Awesome.
Good job, guys. Any like final questions? That's all that we have. Any final questions before we wrap up? All right. And if anything comes up, just, email us as always. We are here to help. Thank you, guys.
Thank
Are we
you.
getting the lecture slides sent? I can send these to you because I created them. Again, I meant to reach out to a couple of you guys. I know you sent me emails about like the other charts and asking if we kind of had templates for those. That wasn't something that I specifically had a template for. I don't believe that we can share those with you because they're
Yeah.
not from us. But this one, this PowerPoint slide, I can definitely share because I created that.
Yep.
So, yeah.
Yeah. And it'll you guys will get a lot out of making your own like stuff like that. That's like the best way to learn is by making like your own like study guides for
Mhm.
that stuff.
Yeah.
Yeah.
All
Did
right.
you guys record this?
Yes,
Yeah.
I did record it. I'm gonna try to upload it. Zoom can be like really bad with downloading the video. So like
Yeah.
as long as Zoom downloads the video onto my computer, it will be uploaded and we'll send you guys the link later.
Yes.
Okay,
Yeah.
cool. Thank you.
I can't I don't want to say like guarantee it'll be up, but
But we are recording it right now,
yeah.
so
Yeah, yeah, yeah. We
Yeah.
we get it. Or at least I
Yeah.
get it.
Yeah. Okay.
Thank you.
thank you
All
guys.
right. Thank you
Yeah,
guys so much.
have a
If you guys
nice
have
night, guys.
Yeah, if you guys have any other questions, feel free to reach out to us, okay?